Good morning. Thank you for joining us. This is the Master Plan for Aging System Change Symposium. This is part one, the Long-Term Services and Supports, or LTSS. You will hear that a lot today. Long-Term Services and Supports, Financing, Affordability, and Access. Today is the last day of July, July 31st, 2025. And I'm going to quickly go through the housekeeping so we can get started with the content. I am Carol DeAndres. I am the manager of the Master Plan for Aging, MPA, Stakeholder Engagement here at the California Department of Aging, CDA. Next slide. Want to talk about our accessibility functions. Today we have American Sign Language, and we thank Summer and Bailey as our ASL interpreters. Thanks for joining us today. We have closed captioning. It is available to you during the webinar. To initiate closed captioning, at the bottom of your Zoom toolbar, or at least mine is at the bottom of my screen, you have a CC icon. And if you click on that, you can show captions and view full transcript. And if you do not see that CC, you should have 3 dots, more, check under there. Next slide. The chat function is enabled for panelists, our guests, and CDA staff to share out meeting-related, webinar-related resources and information to all of you attending. And at this point, we're approaching 140. The question and answer function is enabled for questions from the attendees. Please go ahead and use that. We will work to respond to the questions during the presentation, or if we run out of time, we will get back to you. Next slide. Today's recording will be posted on the CDA YouTube channel, and we'll put a link in the chat for where our CDA YouTube channel is. Lots of interesting stuff on there. Our meeting slides and transcript and recording will be posted to the Long-Term Services and Supports, LTSS webpage. And if you have any questions following the webinar, please feel free to email us at LTSS Financing, that's FINANCING, at aging.ca.gov. And now I will turn it over to our director, Susan DeMorris. Susan.
Thank you, Carol. Thank you, and good morning, everyone, and good afternoon to those of you joining us on the East Coast. I am so excited for this first webinar and our combined symposium. You hearing okay? Okay. I'm hearing a little feedback. I don't know if others hear that as well. To me, here in California, it feels like the first day of school. We have lots of students starting next week, as the first week of August, and I feel like we're laying out 2 syllabi, one on LTSS financing, the other on our HCBS gap analysis, and we're bringing the top faculty in our state and nation to educate you all on this syllabus. And it brings so much excitement to me for what's ahead, because we're showcasing for everyone who's able to join this webinar and everyone who watches the recording what is possible and potential and opportunities ahead for our state. I want to start by thanking first and foremost our Governor, Gavin Newsom, whose bold vision in launching the Master Plan for Aging in 2021 led us to this symposium today, really focusing on LTSS financing and home and community-based services. Both are central to the Master Plan for Aging and are interwoven through all 5 bold goals. I also want to commend our Secretary of Health and Human Services, Kim Johnson, who is deeply committed to this work, and to the departments across the Health and Human Services Agency, as well as our sister agencies. A key tenet of our master plan for aging is cross-agency and cross-department collaboration. You will see that on full display today. I'm so excited to be hearing from Anastasia Dodson with the Department of Healthcare Services and to lift up the work of other departments that have contributed to both the HCBS gap analysis and the LTSS financing. I want to thank Sarah Steenhausen and our team at the Department of Aging in the Division of Policy, Research, and Engagement. They've led this work with the tremendous partners that you will hear from directly as soon as I stop talking. So Sarah and team, thank you for leading these two big initiatives and to produce concurrently today through this symposium our findings to date and to map out for us the next steps on both pieces. And then thank you to all of our consultants and contributors and partners in this work. They are serving as panelists today, so you'll get to hear directly from them, but they've done a tremendous amount of work in a very short period of time in state service world. So thank you for the urgency and accelerated pace that you bring to this critically important work. On today's topic, LTSS financing, there is nowhere I go, whether it's on Zoom, Teams, in person, in the office, or in the community. And I can hold up our recent submission to the Administration for Community Living as a shining example. We just submitted our Older Americans Act state plan. We did extensive public comment over a period of time. The leading comment that we heard was around LTSS financing. How do people pay for care? Where do they go to access services? What are the costs? How do they plan? That's just one example, but everywhere we go in partnership with our community, these are the questions that were asked, and today we're starting to answer them. So thank you all very much. I turn it over now to Sarah Steenhausen, and I'm excited to be part of this master class along with all of you. Do I turn it over to Sarah Steenhausen and Anastasia Dodson?
Yes, actually, we're going to hear first from Anastasia. So welcome to Anastasia.
Oh, thank you so much, Sarah and Susan. We're very pleased to be here at DHCS. Thank you to CDA and, of course, all the partners here. I want to emphasize for DHCS, we are very engaged and we look forward to continuing to explore this important policy area. We know there's been very strong interest in this area for many years, and we know that that continues. So glad to be here, part of the conversation. We're listening carefully and thinking, and we're very engaged. So thank you so much.
Wonderful. Thank you so much, Anastasia. You've just been a tremendous partner, and we recognize that you are soon departing your role at Department of Healthcare Services, but just want to recognize the tremendous work you've led and your long career in public service. So thank you for everything. At this time, I'm really excited to get our program started. I want to start with the slides. If we could have the next slides up. I'm assuming that most of the attendees today come with the same definition, but since we're grounding our whole conversation in long-term services and supports, we want to make sure that we're all on the same page as to what we are referring to. So long-term services and supports represents the non-medical functional support that people need, help with their activities of daily living, such as bathing, dressing, eating, walking, transferring, as well as other instrumental activities of daily living like shopping, meal prep, financial management, and others. Long-term services and supports can be received in either a home or an institutional setting, and it can be provided by paid and or unpaid family caregivers. Next slide. When we think about the issue of long-term services and supports financing, it really is one of the key prongs of the master plans for aging's approach to long-term services and supports system change. I just wanted to give us a few seconds to ground what these efforts are, because you really can't solve the challenges of our long-term services and support system unless you really address each of these four prongs. Navigation, the first issue is many people don't even know how to access services or where to go for help. We're all very aware of the tremendous fragmentation in our system. And this represents our work around developing a more seamless system through a no wrong door approach to accessing information and support. Second is access. So even if we have a very streamlined system, we know that people can't access the services they need across the state. So this is what we're going to be having a conversation today on part 2 of our symposium that looks at the study we've done in partnership with Mathematica to look at home and community-based services access across the state. Third is workforce. So clearly, if we build out our home and community-based services infrastructure, we have a much more navigable system. We really will have nothing if we don't have the workforce to care for it. So another key component of our master plan on aging work is addressing the workforce issues. And then fourth, and finally, the subject of today is long-term services and supports financing. We've heard so loud and clear from our stakeholders, as Susan was saying, that this is a really, really critical issue, not only to Californians, but to people across the country. It is causing people who are particularly those who are not eligible yet for programs like Medi-Cal, who have no way of financing the cost of long-term services and supports. So we undertook this initiative today to really look at a broad range of policy and program solutions to get at this issue of LTSS financing. And we're so proud to be introducing you today to this work. Next slide, please. So before I get started, I just want to underscore how incredibly fortunate we were to receive $5 million of general funding in the 2022 state budget. And we were given the ability to conduct research and analyses to develop options for improving LTSS financing and affordability in line with this key goal of the Master Plan for Aging. So it's with these resources that we have been able to undertake today's work. We have until 2026, end of June 2026, at which point we will release the final report. But we wanted to bring everybody together today to get a look at our progress and the partners and the work to date so that we can hear from you. We can hear your questions, your comments as we continue to carry out this work. So at this point, it's my tremendous honor to introduce you to our lead on this project, Mark Cohen, who is the co-director of the Leading Age LTSS Center at UMass Boston and has just been the most incredible partner in this work. And we, along with our colleague Gretchen Alkema of Wolf Eagle Institute, the two of them have really helped architect design the way forward on this. So Mark, I'm happy to hand it over to you.
Thanks so much, Sarah, and to the entire CDA team for the opportunity to both work on this important initiative and begin to socialize some of the work that has been completed by our many talented partners, whom will be introduced shortly. Let me begin by pointing out that this initiative is both ambitious and bold in what it is trying to accomplish, and laser focused on the ways that we hope to get there. Specifically, as you can see from this slide, we have 4 primary objectives. First, we're conducting significant research and generating new data in order to outline for the state the current and projected needs of California's older adults and people with disabilities who fall in the overlooked middle, a group that we will have much more to say about throughout today's webinar. Second, we're conducting policy analysis and developing a broad set of options, along with a description of specific program parameters for the state to consider for addressing the needs of this population. And we're doing so in part by surveying approaches that are used in other states and localities across the entire United States. Third, we're exploring how we might use Medicare as a chassis for a new home and community-based care benefit that could help address the needs of the overlooked middle population. Specifically, we're speccing out model particulars as well as conducting actuarial analysis to look at both the costs and benefits of such an approach. And finally, in order to deepen our understanding of the population's needs, we're extensively engaging with this population through significant consumer and stakeholder engagement. Next slide. Now, the only way to accomplish these objectives is to assemble a very diverse team of partners, all of whom bring to the table deep subject matter expertise to address these objectives, a track record of delivering high-quality results, and the ability to think creatively together to assure that the very best research and analysis informs whatever we put forward to the state. And this slide highlights the set of partners working on this initiative. You're going to hear from many of the leaders of these teams today. Next slide. The foundational question that we must answer for ourselves, and that informs all of the bodies of work that we're talking about today, is how do we operationalize a definition of the overlooked middle, which is the target market that we're focused on, the target population that we're focused on. In this slide, we provide a broad conceptual overview of how we're defining the overlooked middle. Now, in developing this concept, the team agreed that it had to have a number of important attributes. The definition had to be easy to communicate, conceptually appropriate, and easy to measure. The data to track this population had to be consistently collected, publicly available, and tracked over time. And the upper and lower bound thresholds for defining this group would need to be expressed in terms of a percentage of the federal poverty line. And this is because eligibility for other public programs like Medi-Cal, for example, are keyed off of this. For our purposes then, the overlooked middle is comprised of households that can initially afford basic living needs as measured by the Elder Index in the community. These are people or households who would have to diminish their living standards. That means meaningfully reduce expenditures on basic living necessities if and when LTSS needs arose and required moderate amounts of service to take care of. And finally, these are folks who do not qualify for Medi-Cal coverage, either before or right after the onset of an LTSS need. We're going to provide more detail about this group, and we'll now begin the substantive part of our webinar by focusing on the consumer and population perspectives and the challenges and concerns of the overlooked middle. Sarah, let me turn it back to you.
Sorry about that. Thank you so much, Mark. Really appreciate your overview of how we're defining the overlooked middle as it helps frame the work that we're undertaking. It's my honor to now introduce Dorothea Polk, who's a project manager with Community Catalyst, Miranda Kunkel, who is a consultant with Collaborative Consulting, and Lisa Sugarman, who's a senior fellow with NORC. Together, Dorothy, Miranda, and Lisa have worked to design a focus group process as well as a survey of Californians to really understand what is the consumer and population perspective that we are solving for. So I am so happy now to turn it over to you, Dorothea, to walk through. Get us started.
Thank you for that. Hello, everyone. My name is Dorothea Polk, and as mentioned, I'm with Community Catalyst. If we could go to the next slide. In partnership with Collaborative Consulting, we conducted the consumer and stakeholder engagement. The goal of the engagement sessions were to understand the real-time experiences of the overlooked middle through the eyes of consumers and stakeholders. We achieved this by hosting 9 consumer and stakeholder engagement sessions. To garner a breadth of input, we hosted 3 in-person sessions across 3 California counties and 2 virtual sessions, 1 in Spanish and 1 in Cantonese, each with overlooked middle adults. We also conducted a virtual session focused on adults with disabilities who are working and a virtual session for caregivers of overlooked middle adults. For each of these sessions, we partnered with a host organization to ensure that we heard from the community and had that further connection. Additionally, 2 stakeholder engagement sessions were held with Aging and Caregiver Resource Center staff. Next slide. During these sessions, we had guided discussions on financial needs and concerns. We asked broad questions tailored for each population. For the sessions with the overlooked middle adult and adults with disabilities who are working, we asked questions such as, what concerns you most when you think about growing older? And how do you think your needs will change? For the caregiver sessions, we also asked similar questions, but we made sure to ask questions that were also focused on caregiving supports, such as what support or services would be most helpful to you as a caregiver. For the stakeholder sessions, it was encouraged for them to think outside of supports beyond just additional funding. For those sessions, we asked questions such as, what challenges do consumers and caregivers face in affording long-term services and supports? And how do these challenges impact them? Through these sessions, we received great information and input from which there were clear themes. I now pass it to Miranda, who will share out more information on those themes.
Thanks, Dorothea. If I could get the next slide too, please. So I'm going to spend just a couple of minutes talking through the 8 themes that emerged from our engagement sessions. So first, within financial security, participants across California are really feeling the tension between the rising costs of living on a fixed income plus expensive long-term care, either currently or care that they're anticipating they will need at some point in the future. And with the overlooked middle, many mentioned being able to make ends meet with just their basic living needs currently, but that any unexpected expense, like a hospital stay, or if their care needs were to become more severe in the future, they wouldn't know how to afford that. And although financial security came up as its own theme in our sessions, you'll see as I go through the rest that financing and affordability is really intertwined in a lot of these other areas as well. Within healthcare, a need for consistent access and quality were the overarching sentiments. Many experienced California's healthcare and social services systems as fragmented. Adults in rural areas in particular mentioned things like long wait times, limited provider availability, limited access, although all of these were mentioned in sessions across the state as well. In our non-English sessions, finding linguistically and culturally appropriate providers was also brought up. Within housing, the primary concerns here were again financial, so rising rent and just the cost of housing upkeep, as well as the physical demands of maintaining one's home as they age. Participants also mentioned housing accessibility and the lack of being able to find sort of move-in ready, accessible housing, and that adding any additional modifications after, like a zero entry shower, a wheelchair ramp, was often unaffordable. Next is transportation. So we really heard that transportation is so critical to adults' independence. And across the sessions, participants described experiences with services being inconsistent, unavailable, or again, inaccessible for certain mobility needs. And people with disabilities shared the additional challenges that they often face in using paratransit or needing to get vehicle modifications, again, rarely covered by insurance and largely unaffordable for some. Social engagement came up almost as a resilience factor. So adults recognize the importance of staying connected with friends and family and their communities as they age. But things like social isolation and loneliness tend to worsen with age, particularly for adults who either live alone or live in a rural area. And some mentioned that in engagement opportunities that do exist, there is sometimes a lack of either physical accessibility or environments that aren't culturally welcoming. Navigation also came up quite a bit, so people recognize that California does have a lot of resources and programs, but that they may be hard to navigate. It's challenging for people to know what they qualify for, what they don't qualify for, how to access various services. There was also mention of technology, so as I'm sure we all know, a lot of resources and services are available online now, but especially among the older adults we spoke with, there is a hesitation to fully embrace online service delivery. getting into at-home care support, receiving care in one's home is highly preferred, but many experience it as not feasible, either because it's difficult to find quality caregivers or because of financing. Again, especially for the non-Medi-Cal population, paying for caregiving out of pocket is unattainable for a lot of participants. And finally, family caregivers. We heard from a diversity of caregivers, primarily spouses and adult children. Caregivers talked about the immense toll that being a caregiver is taking on them, whether it's financially, physically, emotionally, mentally. There are some resources that can help, such as respite, training, help navigating services, but often with the limited time the caregiver has, it's hard to navigate all of that. So that is a very high-level overview of the themes and sentiments we heard from our engagement sessions. And I'd now like to turn it over to Lisa at NORC for some survey results.
Hi, everybody. Thank you, Miranda. I'm really pleased to be with you guys today and to share a few highlights from NORC's recent survey exploring California adults' ideas on care as they age, including their worries and concerns about their potential future long-term services and supports needs. Next slide, please. The population that we surveyed for this, the population we surveyed were adults that were age 50 plus living in California with a household income that is at or above 139% of the federal poverty level. This aligns with a population who is not currently eligible for Medi-Cal. The survey sample was drawn from NORC's AmeriSpeak panel, which is a nationally representative probability-based panel. The survey, designed in collaboration with UMass Boston, was fielded in late spring 2025, primarily over the internet. We obtained almost 1,300 responses from the target population. Next slide, please. And this slide provides a summary of key characteristics of the responding population. Roughly half of the sample are female, age 65 and older, non-white, and have an education less than a college degree, and retired. About half are retired. About 1 in 5 respondents live alone, and most are homeowners. Next slide. 15% of respondents were correctly aware of the likelihood that they may need long-term services and supports at some point in their lives. Another 21% were aware of who covers the costs of long-term services and supports. Only 4% of respondents both acknowledge that they may need long-term care at some point in their life and understand how those care needs are typically paid for. These individuals tend to be more educated, higher income, and with greater than average assets, and are also homeowners. Not having a correct understanding of the risks and costs of needing long-term services and supports may prevent or delay people from making preparations or considering options for their future care needs. Next slide, please. We asked survey respondents about their greatest aging-related concerns. The cost of health insurance and not having enough money to live on rose to the top as the most pressing concerns. While the average duration of care needs is closer to 3 years, over 60% of the population responding to the survey was not confident that they could pay for at least 2 years of long-term services and supports costing at least $100,000. Most respondents said they are concerned or very concerned about having to cut back, using up their resources, the affordability of care, and having enough money to pay for care needs. Next slide, please. We also asked survey respondents what concerns they had about finding and accessing care, finding high quality care, being able to control where and how they get that care, and having caregivers who treat them with dignity and respect were respondents' greatest concerns. Those most concerned tended to be younger, in fair or poor health, and with lower household assets. Next slide, please. 6 in 10 of the survey respondents currently or were previously family caregivers. They are most concerned with not being adequately prepared to meet their care recipients' needs. They're also concerned about taking on too much of an emotional challenge. Other top concerns amongst caregivers was using up money now that they may need when they retire, balancing work and caregiving, and being able to care for their own health. Next slide, please. This was a quick tour through the survey. The findings from the survey are just some of the top line findings. We're continuing to analyze the data further to look at how different subpopulations think about long-term services and supports in their preparation. We will be fielding another survey in collaboration with UMass Boston in the fall that explores Californians' perspectives on different solutions that may be able to address those concerns. Next slide, please. I just want to say thank you to CDA for the opportunity to share these results, and I'm going to hand the presentation back to Sarah now.
Wonderful. Well, thank you so much, Lisa, Miranda, and Dorothea, for providing such an important focus on what people are thinking at this point and what our plans are and how this will inform our work. At this point, I'm really, really pleased to introduce Rich Johnson, who is a senior fellow with Urban Institute, and Jen Malinsky, who is the director of the Housing and Aging Society program at the Harvard Joint Center on Housing Studies. We are so pleased to hear from Rich and Jen, who have just led some amazing work in analyzing the population demographics and an analysis of that, along with a real focus in on our California's housing supply and the extent to which we might be able to look at the housing supply as a form of home equity to pay for LTSS needs of the overlooked middle. So at this point, I'm going to turn it over to you, Rich. Thank you.
Thank you, Sarah. I'd like to start by acknowledging my co-author in this work, Damira Kosic at the Urban Institute. And what we're doing is projecting LTS affordability and prevalence in the state. Next slide, please. So we're addressing 3 research questions. First, who can afford to cover paid LTSS in the state out of their own resources? Who in California has LTS needs? And then how much will that population grow over the next 25 years? Next slide, please. So our estimates come from the Urban Institute's Dynamic Simulation of Income model, DynaSim. It was developed and maintained by the Urban Institute, and it simulates key demographic, economic, and health events through 2100. It's a nationally based survey, but California is a large enough state so that we can make reliable projections for California. And we're using special weights to ensure that our projections are consistent with those from the state's Department of Finance and with population distributions from the American Community Survey for California. Next slide, please. So our first research question, who can afford to pay LTSS out of their own resources? Next slide. And we do this by comparing household financial resources to basic needs and LTSS costs. And those basic needs come from the Elder Index for California, which is compiled each year by researchers at UMass Boston. And it consists of basic spending needs on things like housing, medical care, food, transportation, and miscellaneous expenses. And these needs vary by housing tenure, so whether you own or rent, and if you own or you have a mortgage or not. They differ by whether or not it's a single household or a couple household, and by health status. For financial resources, we're considering both income and also financial wealth. So the idea is that some people can dip into their savings to cover their LTSS. And financial wealth includes basic savings, but also retirement accounts like IRAs and 401ks. We are excluding the value of real assets, things like home values, other real estate businesses, because those are more difficult to liquidate in the event of LTSS needs. We're also reserving up to $25,000 in wealth that we assume that people want to keep in reserve in the event of an emergency, such as unexpected home repairs, unexpected medical expenses, and the like. And so we're going to show LTS affordability for different income groups as defined relative to the federal poverty level. Next slide, please. So this chart shows the distribution of income for the California population ages 50 and older. So if you just want to focus on the second and third bars from the left, that first bar is the share with lower middle class income, so 139 to 250% of the population. They account for 15% of the population. The next category is people between 251 and 500% of the federal poverty level. They account for 26% of this older population. So that combined middle group accounts for about 4 in 10 Californians ages 50 and older. Next slide, please. So the other question we have is how much LTSS do people really need? And so we consider several different alternatives because there's so much uncertainty about how much care people will need. So one area in which this measure varies is on the intensity. And we consider 2 alternatives. One is moderate, the other is extensive. So for moderate, we're assuming $50,000 per year is needed. If you take that $50,000 and use it to purchase home care at $37 per hour, which is the median price in California in 2023, that would enable you to purchase 113 hours of care per month, or almost 4 hours a day. That is a little bit less than the average amount of home care received by people who receive home care. That's 138 hours. So 113, a little bit less than 138. If we other measure was extensive home care that was assumed to be $100,000 per year. That would get you about 226 hours of paid home care per month, almost 8 hours a day. That's a little bit more than the average amount of home care received by people receiving home care when they have severe cognitive impairment. So among those people, the average was 206. Here we have 226 per month. Another way of putting this into context is the median cost of nursing home care. In California, a year of care would cost about $137,000. So again, a little bit more than our extensive amount. So for intensity, we have that moderate and extensive. We also vary things by the number of years in which you might need services. We consider 2 options, 1 year or 2 year. 2 years, about half of LTSS users, paid users, receive care for less than 2 years, just to put that in some context. And then finally, this question of who would have to be covered by these resources? Is it just yourself, or might your spouse also need coverage at the same time? So we consider both of those alternatives as well. And if you go to the next slide, we see how these needs compare to income. So each bar shows total spending needs for single people, and this is for renters, for homeowners without a mortgage, homeowners with a mortgage. And the blue bar shows basic spending needs. So for a renter, a single renter, that's about $39,000. For a single homeowner without a mortgage, about $27,000. For a single homeowner with a mortgage, much more, about $49,000. The gray bar then is, well, then if we were to add on a moderate amount of LTSS, that's at $50,000. The yellow bar then, the yellow segment of the bar is then an additional $50,000, so that the gray and the yellow combined give you $100,000, that extensive amount of LTSS. So you see that people with 138% of FPL would have difficulty meeting in general just their basic needs, and certainly could not cover any LTSS. At 250, most people can basically cover their basic spending needs, but again, not much left over for even moderate LTSS. At 500%, we're seeing that single people can cover a substantial amount of LTSS, but not always that full moderate amount. And then even at 800%, still couldn't cover the extensive LTSS in general. Now, remember, this is just for income. So we're going to go for a minute and recognize that people can dip into their assets. On the next slide, please, that just shows similar results for married couples. You see that the basic spending needs are more here, but the general pattern is similar. So now let's go to the next slide and bring assets into the picture. And so this slide shows the percentage of California adults ages 50 and older who can afford LTSS under our different measures. So that first blue bar shows how many can afford 1 year of moderate care for themselves. The next gray bar, that's 2 years of moderate care just for yourself. The yellow bar is 2 years of expensive care. And the pink is 2 years of extensive care for both the self and the spouse. And we show how affordability varies by income. So for those people with less than 139% who general of income relative to FPL, those people generally qualify for Medi-Cal. You see how important that is because they simply can't afford to cover any LTSS on their own. The next group, 139% to 250% of FPL, this is that lower and middle income group. You see that about a quarter of them could afford a year of moderate care for themselves only, but 3/4 couldn't even do that. Only 21% can afford 2 years of moderate care for 2 years of moderate care for themselves, and then it's less. Fewer can afford even those other types of care. Things look much better for the 251 to 500% of income, that upper middle class group. About 3/4 can afford 1 year of moderate care. About 2/3 can afford 2 years of moderate care. And about half can afford 2 years of extensive care. But again, there's substantial amounts who cannot cover those needs without getting help from someone else. And then the story looks better for people with higher incomes. If you go to the next slide, this just shows how affordability varies by demographic groups. So this is for people 50 and older. It's showing the share who can afford 2 years of moderate LTSS, and this is just for the middle income group. So those people between 139 and 500% of FPL. So overall, half of people can cover 2 years of moderate care. But we see that Black adults and Latino adults, their ability to afford that is much less. It's only about 35, 39%, compared with non-Hispanic white adults, 60% of that group could cover care. And these disparities reflect the well-known wealth disparities that we see in the population, both in California and across the country. Married people can do better in terms of affording LTSS than not married people. Again, the married people tend to have more assets, not much difference between men and women. If we go to the next slide, we turn to our next research question: who has LTS needs? And here we're defining that as requiring help with 2 or more activities of daily living or having severe cognitive impairment. And we see the basic finding on the next slide, which is that people below 65, these needs are not very common, but needs increase rapidly with age, going from 9% for people in their late 60s and early 70s to 46% of people ages 85 and plus. If we go to the next slide, we'll see how that varies across the population. And we see that's really concentrated among people with lower incomes. This is showing the share with LTS needs among the 65 plus population. Overall, it's 17%, but it's 26% among people with incomes below 139% of FPL, only 10% for people with incomes above 800% of FPL. And again, that income, that relationship between low income and high health needs is well established, reflecting both that low income people have less access to healthcare, but also that low income people have lived in general, less healthy environments under more stress over a lifetime that really accumulates and leads to more LTSS needs. The next slide, please. We'll see some just quick variation in terms of demographics. More common, these problems, so this is 65 plus again, more common among Black and Latino adults than among white adults, partly reflecting their lower incomes. Also much more common among people who are not married than people who are married. The high numbers for not married people largely represent their greater age, so that not married includes a lot of older widows. Also, women somewhat more likely to have needs than men. Finally, our last, on the next slide, our last research question: what do the total numbers look like? And we see on our last slide, if we could just go to that one, please. This is showing the share of people with, I'm sorry, the previous slide, 50 plus with LTS needs. It's about 1.3 million in 2023 overall. It's going to double over the next 27 years. So in 2050, we're going to have 2.5 million people with LTSS needs. Largely, this reflects the aging of the population. So it's not the case that older people are more likely to will be more likely to have LTS needs in the future than today. It's just there's going to be many more older people, particularly people over 85. And we see the same pattern for people with in middle income people, that's the gray bar, increasing from about 500,000 today to about 1.1 million in 2050. So LTS needs are widespread. It's a growing problem in California, and many middle-income people simply don't have the resources to cover those costs on their own. And with that, I will turn it to Jen Malinsky from Harvard.
Thank you, Rich. Thank you. It's a pleasure to be here. And I just want to thank my colleagues here at the Joint Center in this work, Samara Scheckler and Joe Fang. So our research questions really focus on homeowners in the overlooked middle and whether housing wealth is a potential source of paying for LTSS. Our work, which is still in progress, estimates the amount of home equity that older adults in this group have. We look at the barriers and challenges to accessing it and which subset is most likely to be best poised to use that equity. And we're also thinking about trends in California housing markets that could shift how the shape of people's equity over the coming decades. Next slide, please. So first, who are California's overlooked middle homeowners? If you can go to the next slide, about 2/3 of the middle own their primary home, and that's that box in the middle. And as is true nationally, the home ownership rate climbs with age, peaking somewhere in people's households in their late 70s and early 80s. And as you can see, the middle is right in the middle in terms of ownership compared to the group of households that are under 139% of federal poverty level and those that are over 500%. And again, this is, we're looking at 50 plus, but you can see the age breakdowns there. Next slide, please. Numerically, we estimate that there are about 2.1 million homeowner households in the overlooked middle in California in this age group. It's a racially and ethnically diverse group. You can see that is particularly apparent in the 50 to 64 age group, which is the very first bar on your left. And as that group ages, we expect that that diversity will carry through and the group of older owners will become more racially and ethnically diverse over time. In terms of household composition, most older households include more than one person. You can see that that bottom bar, this is where I'm looking at the chart on the right now, the bottom dark purple color are single person households, and the number of those does increase over time as people age. But overall, it is still more likely that someone is living with a spouse, a partner, or extended family in some kind of perhaps multi-generational arrangement. Not shown here, but I think it's important to note that about 92% of these households are living in metropolitan areas. The share that are living in micropolitan, which is a smaller 50,000 person or under area, or rural is much smaller. Okay, next slide. Before I talk about the potential equity that is available to middle income owners, we want to talk a little bit about the share that have a mortgage. So right now, about 2/3 of that overlooked middle are carrying a mortgage on their home or some kind of housing debt. And that is consistent with national trends. And it's a trend that we're seeing more and more over time. So nationally, among people in their 80s, it's about 31% of folks who have a mortgage, owners who have a mortgage. You can see here in the middle group, it's 39% of that 75 and over group have a mortgage. People in the middle are more likely to have a mortgage than those owners who are lower income, under 139% federal poverty level, a little bit less likely than the higher income folks. Next slide. So before I turn to the equity, I just want to briefly talk about our estimates. We are relying on homeowners' estimates of the value of their homes. That is the best data that we have. For people who own their homes free and clear, they don't have housing debt, the value of their home represents their equity. For those with some kind of mortgage or other housing debt, we estimate the amount outstanding and subtract it from the value. So these are therefore estimates. They're still a work in progress, but I want to share what we have so far. And if you turn to the next slide, our overall estimate is that the median homeowner in the overlooked middle has about $500,000 in home equity. California's property values are quite high, as you know. And so this is, this seems high compared to national levels, but for California, this is what we expect. And median equity is highest among the oldest owners in this group, which is also not surprising. They're less likely to have a mortgage. But we know that to stay in one's house and to access equity, you can't really take all of your equity out of your house. A lender wouldn't allow that. So if you go to the next slide, we've taken a look at what does 80% of that equity look like. 80% being pretty much the maximum that you could seek to tap while staying in the house through something like a refinancing, a cash out refinancing, or a reverse mortgage. And so now we're down to about $400,000 overall. We then looked at differences between owners and those who have a mortgage and those who don't. And if we look to the next slide, you can see that, unsurprisingly, those with existing housing debt, which are on the left, have less equity overall than those who own without a mortgage, who own free and clear. The difference is about $100,000 on average for the 50 and over, and you can see some distinctions by age there. The next question we have is whether people can access that equity. And if we go to the next slide, we'll talk now about the barriers or the challenges. So the next slide, we lay out some of these challenges. Prior research tells us a lot, basically that having equity doesn't necessarily mean that people can easily access it or even wish to. So first off, there's a body of work that shows that homeowners have complicated feelings about home equity as a financial asset. On the one hand, it is a form of wealth. On the other, it is a less liquid form than most other kinds of wealth. It's also tied up in where people live, their feelings of security around that all important, place where people call home, and in feelings about home ownership itself. Homeowners often place high value on being able to pass the physical house or the wealth in the home on to younger generations so that those younger generations are financially secure. This can be particularly true for people who did not benefit from the last decades post-war policies that expanded homeownership. And so today we have deep gaps in homeownership by race and ethnicity, and there may be an extra emphasis on the home as something to bequest to younger generations among folks that have not had that generational ownership. In general, homeowners seem to think about housing wealth as something to be tapped only in extreme circumstances. And research does show that one of those extreme circumstances is the need for long-term care, but that when people use equity for LTSS, it is often not planned. It's more of a response to an emergent need. It's not something that has been set in motion before the need arises. Then, for those who are inclined to tap equity, there may be competing needs besides LTSS. And we heard a little bit about that earlier, including home repairs and modifications, which are two needs that are very prevalent among this very group. For those who do want to tap equity while remaining in their homes, there are basically four main paths: a home equity loan, a home equity line of credit, cash out refinancing, and a reverse mortgage. In our sample, we found that the share of overlooked middle homeowners who currently utilize these products is very small. And we also know from national level research that the share of older adults who use these products is small. The share of people who have reverse mortgages is pretty small. Why is that? I think now we can go to some of the barriers that we see. There's a lack of information about alternatives, just as people often don't know how to begin to access LTSS and supports and services. They may not know how to begin to access the financial information that they need. There can be negative perceptions of financial products, such as reverse mortgages. There can be general debt aversion. People just don't want to go into debt, take out more debt. There can be fears that applications will be denied, so that people don't even put the applications in. Owners who do seek to tap equity to qualify, they must qualify for the financing. So we still have to get through a credit score, debt to income ratio, and people must have sufficient collateral. One study has shown that older owners are more likely to be denied when applying for a refinancing or cash out refinancing, often because they're deemed not to have sufficient collateral. They have overestimated the values of their homes, and it may be that they weren't able to maintain them, and that's part of that reason. Once someone gets through that process, we see higher denial rates related to age, existing debt, credit scores, and a lack of collateral. We know a little bit about this in California. We've looked at Home Mortgage Disclosure Act from California and found that the most common reason that older adults 65 and over applied for any kind of mortgage product was to take cash out of their homes via cash out refinancing. And about half of the loan applications that are made are actually originated A quarter of them are denied, and the rest are withdrawn. And among the denials, the most common reason was too high debt to income ratio, followed by poor credit, incomplete application, and insufficient collateral. So all of this speaks to the challenges of accessing equity. And while we can't at this point in the research answer the question of who is best poised to tap equity, we kind of know that it is people who have the sufficient collateral, the sufficient credit, the low levels of other debt in their household that would get in the way. And many of these products require you to clear your first debt. So to take a reverse mortgage, you have to get rid of your first mortgage. So another complication. Next slide. So the last part of our work is really looking at trends that might affect this landscape going forward, particularly in California. And if you go to the next slide, please, Kelly, we want to highlight just one issue, which is the increasing cost of homeowners insurance, in part driven by increasing numbers of claims from fires, floods, and other events in California and also elsewhere in the country, and its potential impact on housing costs and home values. So we know the Consumer Federation of America has done some great research on homeowners insurance, and we see from 2021 to 2024, the premiums rose 21% in California. These may be unaffordable to older owners, especially those on fixed or limited incomes, resulting in owners purchasing less or even foregoing insurance altogether, which is a thing that happens when people have paid off their mortgage and there's no lender requiring that insurance. Yet we know it's typically required by lenders for those who aren't to seek a reverse mortgage or some other means of tapping equity. The lower insurance coverage by itself can mean owners cannot be made whole in event of a disaster, which results in a loss of housing wealth. We're also seeing trends about owners in high-risk communities where there is more damage, more vacancy, putting a downward pressure on housing values. And of course, this is going to be very regionally different. And already people of color are less likely to have insurance at older ages. So this is just one issue. We're looking at a few more. If you go to the next slide, we're continuing to think about differences in this group and access to equity by household types and other demographic indicators. We're looking at focus groups towards tapping equity and understanding attitudes towards that and looking at some of these additional trends. So thank you. And with that, I'll turn it to Sarah.
Wonderful. Well, thank you so much to Rich and Jen. I feel like we could have, a whole webinar just on the information you released, which is why I want to let everybody know that this is kind of our midpoint, and we're going to be releasing all of this work over the next several months. So you'll have much more detail in addition to what has been provided here. And we will, of course, be releasing this recording after we are finished with the webinar today. So at this point, we've had a really great opportunity to listen to who we are solving for, the consumer and the population's perspectives. Then we heard from Rich and from Jen on what the data say and how we're really defining overlooked middle and what those projections mean, as well as for the housing supply. And now we have an important opportunity to really look at the policy and program landscape. So understanding the challenges and the population needs, what are some of the policy and program options across, publicly financed Medi-Cal, Medicaid, as well as non-Medi-Cal, Medicaid programs, but then also thinking more broadly about what role Medicare could play in this conversation about our LTSS financing crisis. So with this, I'm really pleased to introduce Cleo Cordomenos, who's a director with ATI Advisory, Claire Wickersham, who is Senior Research Associate with Leading Age LTSS Center at UMass Boston, and finally Morgan Craven, who is an director at ATI Advisory. So welcome to you all, and I'll hand it over to you, Cleo.
Thank you so much, Sarah. If we could go ahead to next, let's move one forward. There we go. Well, good morning, everyone. Cleo Cordomenos from ATI. I am very excited to spend the next few minutes sharing some highlights from our recent work, exploring some of the innovative non-Medicaid approaches to support older adults and people with disabilities in that overlooked middle that was discussed earlier by our wonderful panelists. So just diving into it, kind of talking through the purpose of this work we sought out to do, the really core goal here was to create some practical tools to help state and local leaders support older adults and people with disabilities in that overlooked middle thrive in the community. And we're especially, again, looking at those who do not qualify for Medicaid, but for whom those LTSS costs are really going to eat into their ability to, meet basic living expenses. And so the challenge is very clear. People want to remain in the home and community as they age, but those costs are just going to compromise, their ability to pay for other expenses. And so for this group, Medicaid LTSS is not an option. And so our goal was to identify and elevate real world scalable programs and policies that seek to fill this void. And not to bury the lead here, we found over 200 programs across the country that can be replicated or adapted to further fill this fill this gap. Next slide, please. So how did we go about doing this discovery work? Simply put, we took a multi-phase research approach to identify programs and policies operating beyond Medicaid. And so first, we held some landscaping conversations with experts across aging, disability, LTSS financing, and more. Then we conducted national desktop research to map a broad universe of programs across 13 categories I'll cover on the next slide. We launched a survey to expand and validate our findings. Oh, apologies. Prior slide, please. Thank you. And then finally, we conducted in-depth interviews to develop richer case examples. And this process led to two key deliverables that we are excited to share soon. One that we're really excited about is a searchable, what we're calling opportunities compendium that catalogs these more than 200 replicable programs happening at the state and local levels across the country outside of Medicaid, really servicing that overlooked middle population. And I will unpack the compendium more next, but let's stay on this slide still. I have one more comment, and then accompanying the compendium, we have a summary report that distills key themes and case examples featured in that very rich resource that will be available to stakeholders soon. Next slide, please. Great. So with the remaining time, I want to dive deeper to really characterize and illuminate the opportunities compendium. And so as shown here and mentioned earlier, we cataloged about 205 program and policy examples that fell into 13 major categories, all focused on supporting older adults and people with disabilities to live in the community. And so what's striking is the range of areas covered. And we heard earlier the great findings from the survey work really emphasizing, what it takes to support people in the community. And it's really, looking across housing, transportation, nutrition services, the needs are varied and great. And so across these categories listed here, we found, quite inspiring examples of non-Medicaid innovation. I'll highlight just a few from the more than 200 we found. And then when this resource is available, absolutely encourage all to interact with, engage with the programs, many of which are operating the states from, those on the call today. And so one in Pennsylvania, when we're looking at caregiver supports, for example, Philadelphia has a backup care program that's employer sponsored, and it offers city employees, up to 8 days of low cost backup care each year for adult loved ones. And so with flexible options like in-home care and reimbursement for trusted personal networks, this is a really strong example of how employers can support caregivers in meaningful, practical ways. And I emphasize that example because it talks about, the opportunity of looking across sectors, looking how employers can support their employees to support an aging loved one. And then in Minnesota, when we think about transportation, there is what's called the Go Marty initiative that's breaking new ground using accessible autonomous vehicles supported by onboard operators to offer free rides to older adults and people with disabilities across more than 70 locations in the state. And lastly, one of the group's favorite and one of the most inspiring in Illinois, their Hope Meadows program offers a quite powerful model of housing-based community interdependence, an intentional intergenerational neighborhood where older adults live alongside foster families and contribute, a certain amount of volunteer hours each week in exchange for affordable rent. And so this is just a very small sample of some of what's featured in here, and they really show what's possible when states and localities design intentionally for the overlooked middle. And as we close in the last minute or so here, what we found is as California and other states look ahead to transforming LTSS financing and delivery, we hope this work can serve as a roadmap for bold, and inclusive innovation in this space, and a way to really, ensure that we are looking at the overlooked middle population and thinking about how we can support outside of Medicaid LTSS. And that is a good segue to our next our next presenter. But thank you all.
Welcome, Claire.
Hello. I'm Claire Wickersham. I'm here with my colleagues today, Jane Tavares and Mark Cohen from the Leading Age LTSN Center at UMass Boston. And today I'm excited to take a few minutes to share some highlights from our recent work on Medicaid innovations to improve access to long-term services and supports, or LTSS, for middle-income older adults and people with disabilities. Next slide, please. So as a part of California's LTSS Financing and Affordability Initiative, we developed a compendium that catalogs Medicaid efforts across the country that aims to improve LTSS access for the overlooked middle, those who are above Medicaid eligibility but still struggle to afford care. So we focused on how states use Medicaid options to expand access to home and community-based services like respite care, case management, and home modifications. And the result is an Excel-based tool that allows users to filter by state, by program type, eligibility, and services provided. Next slide, please. So to build the compendium, we used a combination of academic and policy literature, desktop research, and expert interviews. We prioritized waivers serving older adults and those with disabilities, and especially those with creative and transferable strategies. For each program, we extracted details on eligibility, services, and program design, and then we organized the findings to allow for cross-state comparisons and broader applicability. Next slide, please. This is just a snapshot of a portion of what the compendium catalogs and looks like. Some key features to note are some filters, which allow users to narrow by state or waiver type or population. And then we also have links. You can't see it on this screen, but they are there, where it points to documents where further information is available. Next slide, please. So we looked at a number of programs in depth and have identified some standout examples that reflect the range of innovative approaches that we cataloged. And each of these approaches offers valuable lessons that could be adapted in other states. While we don't have the time to go over all of these today, they will be cataloged in the report. And we hope this compendium helps policymakers, researchers, and advocates identify replicable models to fill gaps in LTSS coverage, especially for those ineligible for traditional Medicaid. And with that, I will turn it to the next speaker.
Hi there, thanks so much, Claire. So the next section we're going to be reviewing is introducing the concept. If we could actually keep scrolling forward, and one more slide, sorry. Perfect. So what we are introducing here, if you want to go back one more slide, is the goal of this particular project was the state wanted to say, what would it look like to design a model of care within a publicly funded program that could serve the overlooked middle. So we've defined this challenge, repeatedly over the course of this webinar, and so I'll skip that, but really wanted to highlight that the goal of this model was to really explore whether Medicare could sustainably deliver some level of LTSS to this population. So this is an inquiry that's been rooted in state leadership, but the research and sort of concepts that were explored here are really designed for national applicability. And so the question was, could this model that we come up with ultimately serve and improve access to and quality of care for individuals in this overlooked middle, and ultimately lower healthcare costs, including for Medicaid and potentially including for Medicare and potentially Medicaid spending. And so as we were exploring the feasibility of this, the goal was to consider how we might align this model. And so what we ultimately did was to test out and see what this concept might look like was to determine, would it be possible to design a model that meets the statutory goals of cost savings and quality improvement under, for example, a CMMI model. And so that's really the structure that was taken here. And so what I'm going to go through today is what this looks like and what some of the thought behind this conceptual model is. Next slide. So first was really defining the need and identifying whether there's an opportunity for savings. And so as a first step in taking a look at this from a quantitative perspective, ATI did some data work and estimated, what would a potential target population here look like? And is there an opportunity for savings? Later on in the project, there's actuarial work that is being conducted to see in more detail what would this actually look like in practice potentially. But this preliminary data here really shows a compelling case. So what we're looking at here is we have identified a California traditional Medicare non-dual population. And so looking at this California specific data and then using a claims-based algorithm that's based on frailty and disability, we sort of compared that to spending to see, is there potential for savings? And so what you're seeing here in the bright blue and that darker blue really shows that the spend for individuals, once they reach that mid to late frailty, it really increases within Medicaid. And so what we had sort of started this concept with is, if it is possible to provide some kind of limited HCBS benefit, would there be a potential to reduce that spending in that mid to late frailty group if they have some of the supports that they might need to stay safely in the community? And so what we ended up designing is listed out on the next slide. So first is model eligibility. So after a lot of great design work and collaboration from the state, we sort of assessed what a straw model might look like for this concept. And so what we've identified would be this. First would be, if there were to be some kind of demonstration or model rolled out in this manner, it would be focused on traditional Medicare enrollees, and that includes those who are aligned or not aligned with an ACO organization. They would be individuals who are living in the community, including homebound individuals. They would reside within a service model area, assuming this model was potentially geographic based, they would need to be within that area. And then lastly, and most importantly, they demonstrate a level of frailty that would make them, potentially benefit from HCBS. And so on the next slide, I'll talk about what the structure of the model benefits might look like. And so here we really tried to think about the recognition that individuals have a robust set of needs in HCBS. And so rather than having a really expansive and prescription-based benefit package, we thought about what are the things that could really be meaningful to keeping people in their communities. And so first was service navigation. So we recognize that there are a lot of benefits out there that help individuals both medically and also socially related to those social health needs to stay and support them being in the community. And so as an example, this service navigation would be intended to help individuals say, hey, are you adequately accessing all of these other benefits that you might have the ability to get, like VA benefits, for example. And then the next is really the core of this is the HCBS benefit. So this is structured based on an annual dollar limited benefit. And within that limited dollar benefit, you could get everything from medically tailored meals to personal care. So it really spans a number of HCBS based on that individual's needs. And then lastly is incorporating what's called the capable model. And so this is probably something that a lot of folks on this call have heard about, but it is a home-based, time-limited program with services from an occupational therapist, a registered nurse, and a handy worker to make sure that this individual can improve their health, independence, and safety within their home. So individuals would not be required to participate in this program, but recognizing this program's success in generating savings and keeping individuals functioning in their homes, we thought that this would be a very meaningful benefit that could contribute to this model benefit. So all of this to say, really wrapping it up, again, this is really a concept that's being put forth, but the purpose here is to show that this could really be a viable solution. It is very possible that something like this could move forward. And so, some type of HCBS benefit could be delivered in a meaningful and fiscally responsible manner here. Okay, thank you so much.
Terrific. Thank you so much to each of you for such important depth of information, and particularly really excited to think about new emerging opportunities at the federal level and what that could mean. So at this point, we've had such a rich conversation about a variety of approaches and research that's been done, and really pleased to introduce our reactor panel. Each of these individuals are leaders in these subject issues at the state and federal, national level, and are going to provide just a few comments and thoughts for our consideration as we move forward with this body of work. So it's my pleasure to introduce you to Hagar Dickman, who is Director of the California Long-Term Services and Supports Advocacy for Justice in Aging, and is also a co-chair of our Disability and Aging Community Living Advisory Committee. Narda Apakchi, who is Vice President of Policy and Programs at the SCAN Foundation. And finally, Michael Murray, who is the new State Director for AARP California. So welcome to all of you. And Hagar, I'm going to start with a question for each of you. We can probably remove this slide. Thank you so much. Hagar, Justice in Aging has prioritized the development of a home care system for all, which includes addressing California's long-term services and supports financing crisis. What reflections do you have based on what you learned today, and what do you see as the most important priorities for California at this time?
Well, thank you for inviting me to participate. And for this great presentation. So our work in looking at our system of care is really centered in equity, and focusing on what are the inequities in our LTSS system means looking at what impacts whether someone gets care or experiences unmet needs, and what are the systemic drivers of inequities in our system of care. So we really start looking at our Medi-Cal system and try to address inequities within that infrastructure, and then look beyond to near eligible or overlooked population, as you guys had called it. So I really appreciate the work your team did here in defining and describing the group of folks that will at some point need caregiving but won't be able to afford it. We know that most people will need care at some point in their lives as they age. And what this presentation that we just saw shows is that for many people who don't qualify for Medi-Cal, there are real trade-offs in accessing care. When you need to pay for caregiving out of pocket, unaffordability means that you're really choosing between economic, housing, and food security and your basic care needs. And this presentation really highlights and quantifies these trade-offs, and it also really helps us think through the impact of certain policies on this current underserved population or unserved population, especially from an equity perspective, like looking at disparities around both elevated LTSS needs and limited access. When we try to think through how to fill the care needs of those outside the Medi-Cal system, it's not just that the care is financially inaccessible, there's really no other care system to tap into beyond Medi-Cal. So you really see that in the consumer surveys that you did, when people are trying to get their needs met, they're finding that every need requires looking at a different place to have that particular need met, and often there is really nowhere to look. So that really highlights for us that Medi-Cal is really our long-term care infrastructure in California. And when we're thinking about expanding access, we really need to be tapping into that pre-existing Medi-Cal infrastructure. But there's a lot of work that needs to be done to get that system to be able to serve all the people that need it. There are improvements that need to be made so that Medi-Cal can serve the current eligible population. That work is really focused on closing gaps within the current Medi-Cal population. And then there is expansion of the eligible population. That's really starting to raise that floor so with that we start shrinking and hopefully eliminating the number of people in that overlooked population. And then there are expansions that need to be made to the infrastructure itself, things like investments in services, expanding provider networks, so that, and then things like that, so that the system can grow with the growing need. And finally, there's this financing piece. And for us, that's really how do we add more financial burden to an already burdened system, especially I think given what's coming down from the federal level, there's a tendency right now, I think, to draw back and focus on protecting the current system that we have. But actually, especially because of these federal threats, I think we should be really thinking about how California steps up to maintain, but also strengthen and expand our HCBS system, and not let federal pressures really push us backwards. So our priority right now is to look for opportunities, not just to hold the line, but make progress on those things, even in a really tough environment. And so for us, the LTSS financing question at its core is how do we finance an expansion of our Medi-Cal LTSS system? So stop there.
Well, thank you so much, Hagar. Those are such important considerations, and I think it's a really great opportunity to hear from you, Narda. With the SCAN Foundation focusing a lot of efforts on addressing the LTSS affordability crisis facing the overlooked middle, those populations exactly that Hagar was mentioning that don't have eligibility for Medi-Cal or Medicaid. So what strikes you from what you learned today as key opportunities for federal partners to consider?
Sure. Thank you so much, Sarah. And I just want to say first, too, that I'm just really encouraged by today's conversation and how many brilliant and dedicated people are working on this issue that just simply can't be ignored. At the SCAN Foundation, long-term care financing has really been at the core of the work that we've been doing since our inception. We are also really dedicated to lifting the voices of people who are too often left out of policymaking, those with lower incomes, people of color, those living in rural communities. And so for me, all the incredible work that's been done to capture people's experiences and circumstances to shape this effort really speaks to me. The findings that over 2/3 of older Californians polled were not aware that LTSS availability of LTSS and who pays for it should really be a wake-up call, not only in the state of California, but this is obviously a trend that expands to other states and across the country. Recognizing that many of the options that were discussed today require some level of federal action or coordination, it's really just so important that these learnings make their way to federal policymakers. We actually recently helped to fund a compendium also created with the help of Mark and his team at UMass Boston on all of the various federal long-term care financing policy ideas from over the last 40 years. And so to me, with that, coupled with the Medicaid compendium that was shared earlier, I think what this really says to both state and federal policymakers is please don't start from scratch. There have been longstanding efforts. We know what some of the policy solutions are. We know, sort of the benefits and challenges of some of the various policy options that are out there. We know it's coming down to things like whether we're adding coverage for long-term care to existing federal programs or creating a new standalone program, whether or not that program should be administered by the federal government, states, or some combination, and how program design may exacerbate existing capacity for the long-term care workforce. Again, these are all questions that have been explored, and we have some answers. So there is real opportunity at the federal level to act with confidence. So just really commend, again, the work I've seen here today. It really underscores the fact that the overlooked middle has been left out of a significant portion of the discourse to date, and makes it all the more important that we lead with the population when we're talking about issues like long-term care financing and how that impacts older adults directly.
Thank you so much, Narda, for such important reflections and opportunities that are ahead. So Michael, turning to you, at the state and federal level, AARP has long prioritized the importance of addressing our nation's LTSS financing crisis and in building awareness on these issues through advocacy. From your vantage point as state director, how can stakeholders and partners continue to advance the call for system reform at both the state and federal levels, especially during this time of tremendous change and uncertainty?
Thank you, Sarah, and thanks everybody for what a rich conversation today has been. I'll share a little highlights on some of our policy and work we're excited about at the state level that hopefully addresses some of these issues as well. We certainly have strong policy that supports the creation of a long-term care social insurance benefit. AARP supports the pursuit of private and public sector financing solutions for LTSS. This public benefit could be supplemented by private expenditures, broader Medicare coverage, and Medi-Cal eligibility changes. We believe any long-term care benefit should be equitable and broad-based to ensure that LTSS is affordable for all adults' abilities and income levels, especially as we've heard multiple times today, the overlooked middle. Year after year, when we survey older Americans, they tell us in overwhelming numbers that they want to age in their homes and communities, and we're seeing some of that data today. AARP believes it's time to change course and point ways towards new solutions. Solutions that are desperately needed as our population ages, as the cost for long-term care continue to increase far and above the means of most Californians, and as the availability of both paid caregivers and family caregivers continues to decline. For nearly 8 years, AARP California has been engaged in work that we anticipate and hope will lead to the creation of a state benefit. Our focus at present, though, is on an important public education campaign that's really just getting off the ground. We've collaborated with community organizations, activists, legislators, and unions to advocate for a financing solution to make long-term care affordable, one that gains support from voters, the governor's office, and state legislators. Earlier this year, we launched what we're calling Tomorrow's Caregiving Today, a public education campaign that is encouraging California residents of all ages to learn about caregiving, the complexities, its related costs, and how individuals and families are impacted on a regular basis. It's time to educate Californians. We want to build a base of support among members, non-members, public, people of all ages alike, so they can advocate with decision makers for the creation of this benefit when that time comes. We're especially focused on the needs of the overlooked middle, as we've talked today, the importance of understanding the implications to that population. One of the real reasons we could really launch Tomorrow's Caregiving Today, which is covering 3 key areas. Understanding the impact of changing demographics for an aging population, the impact of the high cost in care and diminishing caregiver resources, and that urgent need for new policies and private sector solutions that support those who give and receive care. Our campaign is initially focused on engaging college and graduate students, but we are going to be branching out to other audiences, which will include many of you on this webinar. We are thinking through how we might modify this effort as we build a base to counter anticipated cuts in Medi-Cal, and how home and community-based services due to the passage of the recent federal law. While we do not anticipate action on a social insurance program at the federal level at this time, AARP does continue to release research that supports our advocacy agenda, demonstrating the high cost of care, the financial and emotional impacts that caregiving places on family caregivers, and that demonstrates that the 4.4 million family caregivers in California are the backbone of our LTSS system. Our top caregiving focus is the Credit for Caring Act, bipartisan legislation that would provide financial relief for working family caregivers. As many of you know, the Credit for Caring Act would provide a non-refundable federal tax credit for up to $5,000 for eligible working family caregivers to help offset a portion of their, out-of-pocket caregiving costs. I hope this provides some insights to what AARP is thinking about, how we're looking at the importance of education, how we can contribute to understand where we will have a voice representing our population, and even those younger, as I mentioned, as we touch those during our education campaign. Really appreciate today's conversation. Thank you so much.
Well, thank you all for your comments and remarks. And we had such a wonderful discussion today with all of our panelists that we unfortunately do not have time to turn it to broader Q&A, but I'm happy to report that we will have other opportunities to engage on these issues. And just as a reminder, each of the bodies of work that you've heard about today will be rolled out over the next few months, several months. So you can follow up with more information, and we will keep you informed of how you can engage in this discussion. So thank you all, and I'm so pleased to now turn it over to our wonderful director, Susan DeMorris, for some closing remarks of this part 1 of 2 webinar series today. Susan.
Thank you, Sarah, and everyone. And yes, very fast and furious walk through a variety of topics. There is a strong nexus with our next webinar that begins in 1 hour around the non-Medi-Cal home and community-based services gap analysis and roadmap. When we talk about the overlooked or forgotten or missing middle, these are the services that they're paying out of pocket for that are non-Medi-Cal services. So I invite you to tune in there. Please follow our YouTube channel, share this with others. Please subscribe to our Engage newsletter so that you get updates. As Sarah said, we will continuously update you on this. This is just the first conversation of many that will follow, and we appreciate your attention today, tuning in, and more to come. Thank you, all of our presenters, and we'll see most of you again at 1 o'clock.